The goal of this synthesis was to identify, review, and analyze the evidence as it pertains to the effect of a delayed antibiotic prescription on ultimate antibiotic consumption in the setting of respiratory tract infection. I was able to find 4 studies that met the criteria that I set forth on the previous slide. One was a meta-analysis, which was nested within a Cochrane review. This represents level 1 evidence pertaining to quantitative research studies. A second study was a multi-site, non-blinded, randomized controlled trial constituting level 2 evidence. A third was a non-randomized quasi-experiment, level 3 evidence. And finally, there was one observational prospective cohort study representing level 4 evidence. Now, this was not intentional that there were 4 studies, each of which had an evidence level 1 through 4, but that was just the characteristics of the studies that I found. Now, I want to be clear that not many studies looked solely at antibiotic consumption or antibiotic use as the only primary outcome variable. Most had multiple outcome variables that they were looking at, of which antibiotic use was just one. So when I evaluated the studies, I evaluated them solely in the context of how the strength of the study related to evaluating the outcome variable of antibiotic use. In sharing with you my appraisal of the evidence, my goal is not to get into the nuts and bolts of every single study, but instead to investigate the validity of the studies taken as a whole. We're going to start with internal validity, which essentially refers to how well the study was designed and carried out in terms of reducing the risk of bias. So, in any study, we would love the various independent variable groups. In this case, patients that received a delayed antibiotic prescription and patients that received an immediate prescription to be exactly the same. And the gold standard of ensuring that these two groups are as similar as possible is randomization. So, what I encountered in the 4 studies that I analyzed was that randomization via a computerized random number generator was carried out in all of the studies in the meta-analysis, as well as the study by De La Posa Abad et al. In 2016. That's the randomized controlled trial. There was no randomization, unsurprisingly, in the quasi-experiment and the cohort study. So overall, there's a relatively low to moderate risk for selection bias due to a lack of randomization. Essentially, what we're saying is for most studies, it appeared that the control group and the intervention group were pretty similar at baseline. Second, I want to address the issue of blinding. Now, almost no participants were blinded in these 4 studies. Now, we generally undertake blinding to mitigate the placebo effect. Most of us are probably familiar with that. If we, for example, know we're getting an antibiotic, we may be more likely to rate our symptoms as being less severe after we start taking the antibiotic, because we, have that association in our minds already. In this case, because we were evaluating the outcome variable of antibiotic consumption, which is a relatively uncomplicated, unbiased, objective measure, it's unlikely that a lot of bias was introduced into these studies by a lack of participant blinding. And it's also very difficult to blind in these circumstances because the patient needs to know the mechanics of how they're going to delay their prescription and what prescription they're going to take and how much and on what days, etc. So it's quite difficult when you're studying prescribing practices to make the patients entirely blind to that intervention. An overwhelming majority of the studies, including those that were part of the meta-analysis, used patient diaries as the way of determining whether the patient had used antibiotics or not. Several studies followed up with phone calls, in-person interviews, and cross-checking with area pharmacies. But for the most part, um, it was done via patient diary with any mention of antibiotic use in the follow-up period as counting as a positive result. Yes, they used antibiotics. Um, there was little discussion in the literature about whether this was a valid and reliable measurement tool. So it raises the possibility that perhaps the measurement was somehow biased. Now, I assessed this risk as low to moderate because participants likely remembered whether they took an antibiotic or not, something called recall bias when the event that we're trying to um, analyze may have occurred well in the past and the participants may have a foggy memory of it. But given the relatively short uh, follow up periods in this case, I think that's relatively unlikely. And also the outcomes assessors, so those evaluating, looking at the patient diaries deciding whether they took antibiotics or not were also non-blinded. So if they were hoping for a particular result, then it's possible that that could have uh, influenced the outcomes assessors in some untoward way. But really, the outcome of antibiotic use or no use is very uncomplicated, objective, and what we call a dichotomous yes or no, 0 or 1 kind of variable. So again, I believe that there was a low to possibly moderate risk of measurement bias. Filling out a diary while you're ill may seem onerous, may seem like the last thing someone who's not feeling well would want to do. So I was curious if there was significant attrition throughout the study that could have systematically biased the results. However, the authors of the meta-analysis assessed bias as low for all studies within the meta-analysis, and attrition rates in the standalone studies range from 1.7% to 21%. And really, if you're around that 20% attrition rate, dropout rate for a study, you're doing pretty well. So I assess the overall risk of attrition bias as low. I also surmised that if patients didn't trust a particular provider, if they had been assigned to delay their antibiotic, they may have been willing to actually participate with that delay and would be more likely to just take their antibiotic immediately anyway. Um, but this was mitigated by the multi-site nature of these studies. So the De La Poza Abad et al. Study took place at 23 primary care centers in Spain, Little's study at 25 primary care practices in the UK, and then Francis and colleagues looked at 14 primary care networks around Europe. So if there were any individual provider trust issues or variations in how they carried out the protocol, um, this was likely mitigated by using so many different sites. In my estimation, by far, the biggest threat to internal validity in these studies as a whole was sampling bias due to non-recruitment. So in the randomized controlled trial, the quasi-experiment, and the cohort study, providers recruited subjects who were presenting with respiratory tract infection symptoms who were in a primary care or clinic setting. The aims of the study were not concealed, so the subjects understood what the researchers were trying to study, and therefore they may have declined participation if they had very severe symptoms or had a strong belief that they needed antibiotics immediately. So I believe there's a moderate to high risk that the study populations that were eventually recruited into these studies might not have been representative of the reference population of just adults with respiratory tract infection. Importantly, none of the studies reported statistics relating to a number of participants recruited divided by the number of total participants approached. So, if, for example, a study recruited 95 participants and approached 100 participants, well, it's pretty likely that that sample was representative. But if they recruited 95 participants and approached 1,000 participants, and that's an entirely different story. And In Little et al. Study, they did have providers who were recruiting the patients fill out so-called non-recruitment questionnaires, and they did believe that feeling too unwell or concern about the proposed treatment were reasons that individuals refused to participate. So, just further substantiating this possibility that there may have been some risk of sampling bias. In summary, as a whole, the studies had moderate quality in terms of their internal validity. There's significant methodological challenges when working with patients in a real world setting, and I think for the most part, these studies dealt with those challenges well. Even though there was a high risk of sampling bias, other risks were mitigated appropriately.